Much. So as mentioned, I'm Sarah Wilson. I'm a research assistant and PhD student at Newcastle University. And I'll take you through a bit of the key sort of strategies that are coming from my PhD work around how can we promote digital inclusion within healthcare, and how can we make sure that these strategies are adopted within practice as well. So before I get into the whole PhD and my findings from that so far, I'll take you through a bit about how I actually got into this space. So I started, there we go. So I started my undergrad back in 2017, and that was in Newcastle Uni as well. And I did a joint honours undergrad degree in biology and psychology. And then straight after graduating in 2020, I moved down to Sheffield to study a master's in cognitive neuroscience and human neuroimaging, just because I thought brains were cool. And then after about the first semester, I started thinking, okay, what's next? And I always liked the idea of becoming a doctor. So I was like, okay, let's apply to some PhDs. And the first bit of feedback I got was to get any funding to do this PhD was to go out and do some research, get some research experience. So that's what I did. I got myself a research assistant job to run alongside the master's degree. And because this was through COVID, so my master's was all online, and that was full-time, and the research assistant job, also full-time, was also online. So I was able to juggle it from my bedroom in my student halls in Sheffield. And then after the master's degree was done, in August 2021, I moved back up to Newcastle, and I was just a research assistant for about 6 months before starting the PhD, which is a full-time PhD run alongside the full-time research assistant job. And the research assistant job actually fed into and shaped the PhD. So the research assistant job that I was working on back then, it was on a project that was looking at trying to detect dementia a lot earlier than currently possible, using off-the-shelf technology such as the Stream headband, which has EEG sensors on it to measure different aspects of sleep. We'll have a Fitbit to measure different levels of activity. And we also had two smartphone apps. So one was passive, to measure fine motor movements, such as how fast you type a text. And we also had an active one, which was a bit like Wordle, but more looked at cognition. So I had little mini games on there. And my task within this project was to conduct some PPI work to assess the usability and acceptability of these technologies by people who might be using them later down the line. So these are people with cognitive impairments, the carers, and even just general members of the public. And to do this usability and feasibility kind of test and PPI work, I had to make some user guides to fully understand how the technology works and also to support the people who will be using them. And this included a video guide and written guides. So as I was making these guides, I really understood how the technology worked and all the different errors that can come up. And it kind of really surprises about how many little errors was coming up. Because I thought, oh, there'd be an easy task. I'm used to using technology, simple, easy. But no, there was little things like the headband, you had to use your Wi-Fi to sync it up with a mobile app to then sync the data over. But because I was in student halls, I was using a shared communal Wi-Fi, which didn't register with the headband, which then got us thinking, okay, what about those in a nursing home who will also be using a communal Wi-Fi? So my way of coming around this was using the hotspot on my phone. But again, I was thinking, okay, so if people aren't tech savvy and know what hotspot is, that they're going to really struggle with this. So this actually did come out quite a bit in the findings as well. So we ended up asking 9 people to use these bits of technology for about 2 weeks. So we interviewed them a few days after using the technology, after they received it with a set of guides and everything. Then again, we interviewed them at the end of the 2 weeks to sort of get their usability and acceptability. And these 9 people were some carers, and those with different levels of cognitive impairment, including those with frontotemporal dementia, Alzheimer's, and mild cognitive impairment. And one of the key things that we did find from this work was that people didn't have access to good Wi-Fi connection to help that data syncing process. It would just take for ages, it would buffer and would like really annoy people. And also a lot of people weren't confident in using their own technology. So they were saying like using the Fitbit is fine. It's just like wearing a watch. People were used to using that. But the whole malarkey with a phone to sync over data, using Bluetooth to help sync data over, using Wi-Fi, they just didn't understand it. So this got us into the area of digital exclusion, because I was thinking, okay, this is a big area here. And by digital exclusion, I mean sort of barriers that come up surrounding the use. So people struggle to actually use the device because they don't have the digital literacy skills there. They don't have access to either the connectivity, so that's either the Wi-Fi, 4G, 5G, or even phone data signal, or even have access to like a compatible device. We'll have issues around reliability, so sometimes the sensors in, like, say, the Fitbit are sensitive to skin tone colour. So sometimes the sensors aren't reliable across different demographic groups, and also some bias in artificial intelligence models could then affect the reliability of output from medical devices. And we also have barriers around motivation, because some people just don't want to use technology, and we should be respecting that. So as I started looking in this area a bit more, I was really shocked about the amount of people that digital exclusion actually affects. Because you might just think, oh, the sample that we had originally of 9 people, you might just think, oh, that was pure luck that I just had 9 people who struggled to use tech, didn't have access. But it's been estimated in 2021 that 2.9 billion people worldwide are digitally excluded. And of that number, 96% of those are from developing countries. And then also in 2021, it was estimated that 10 million people, that's UK adult population, lack the very basic digital literacy skills to use tech in the digital world. So that's even using the internet, or knowing how to Google things, really simple things that we take for granted. And it's also been estimated that by 2028, that 6.9 billion people will also be digitally excluded when nothing is done about it. So the number will go down slightly, but it's still been quite a lot of people. And I think that's been estimated to be roughly about 12% of the adult population in 2028. So all these figures are from the Good Things Foundation, which is a charity that supports digital inclusion across the UK. So if you want to look for more information about that, there's a link there as well. So I'm actually guessing that although that number went down over recent years, and it's been estimated the 6.9 million people are going to stay digitally excluded if nothing is done to help them, I actually am predicting that it's going to be a bit more, because there's a massive push within research and within healthcare to use more technology to promote healthcare. And this is just a bit of a flavour of what's going on at the moment. So this is a few of the projects that we're currently working on within Newcastle University and a team that I'm in. So we'll have 2 projects looking at the early detection of dementia-causing diseases and how we can use technology to help that. We're also looking at how we can use technology to help communicate air pollution levels and the risk of air pollution to health as well. And we're also looking at how we can use technology to help implement solutions to mitigate the impact of temperature and extreme health. And then also quite recently, there's been an independent investigation of the NHS, which highlighted the amount of outdated technology that's currently being used within the NHS. And there's been a major push to try and use more technology within healthcare, more up-to-date technology to improve productivity within the healthcare system. And there was only one tiny little mention of digital exclusion within this report, and it was in relation to the homeless population and the barriers they currently face to accessing mental health services. So before this issue gets even bigger than it currently is, with all this push to use more technology within healthcare, my PhD looks at investigating the key strategies to promote digital inclusion within healthcare and the different facilities and barriers to adopting these strategies within practice. So it comes with 5 different objectives, and I'll go through one at a time. So the first one is identifying who is actually most at risk of digital exclusion, so we know who we're actually trying to help. So to do this, I conducted a scoping review, which included the grey literature and published literature to identify who is most at risk and also what are the key barriers that these different groups are facing. And from this scoping review, I made this CLEARS framework, which encompasses the 6 different demographic groups that are commonly associated with digital exclusion within healthcare, and also acknowledges intersectionality, which just means if someone's a part of 2 or more of these groups, they're at greater risk of digital exclusion. So the C in clear stands for culture, and in that I've got ethnicity, language, and religion. Under the limit conditions, I have visual and hearing impairments. In education, I've got those who have an education attainment of GCSE level or below or equivalent in other countries. We'll have age, so those over 65 are more likely to be digitally excluded. We'll have residence, so if you're in a rural area, deprived area, or homeless. And also social status, so if you have a low social status, which has been estimated to be about, I think the last time I looked at the numbers, I think it was 20k in annual income for the UK. So that's like the median, I think it's 60% below the median of the country's household income. So by different countries it fluctuates, but in the UK it's roughly about the 20k mark annually income. And then from this scope and review, I've been very lucky to get accepted in a few conferences and travelled over to Cork to present it at a presentation and being able to publish it as a conference proceeding. So that's been really fun as well, to travel over to Ireland and try the Guinness. So then the next step in this PhD is to actually look at what strategies are actually out there, what's currently being used, and what are the facilities and barriers to actually implementing this practice, looking from the perspectives from those underserved groups, those who these strategies are supposed to be helping the most. So to do this, we conducted a systematic review using terms associated with my CLEARS framework, also digital technologies and health inequities, and popped them into Medline, MBase, PsycInfo, and Scopus. And then I was just looking at studies that focused on the strategies that are used to promote digital inclusivity within healthcare. I just focused on qualitative studies because I wanted that juicy detail to realise, okay, what does and what doesn't work and why is that? And I also just looked at publications that were published in the English language, because that's the only language that I know. And also just looked at those between 2012 and 2022, because this paper was first done in 2022. And the 2012 comes from, I wanted to just look at the earliest decade to make sure whatever technology was looking at, whatever strategies that came up, was actually relevant and up to date, because obviously technology advances pretty quickly. So from this, we had about 13,000 odd articles from these databases. And after removing just shy of 3,000 duplicates, myself and 3 others started screening these articles at the title, abstract and full text stage, using a software called Ryan, which is really good at managing systematic reviews, and also is really helpful in when you're working across a big team as well. And then from this, we end up just getting 10 papers that were included in the review. And from these 10 papers, it was quite apparent that a lot of them were like looking at like co-design approaches. So involving underserved groups in the design of a new technology, a new service, anything like that, getting their sort of views to help promote and advance the service that they're given or technology they're building. And also only 2 of them were looking at outreach programs. So outreach programs are where a research team or a healthcare professional group go out in the community and actually deliver a service or support them in that way. And then to actually pull apart what actually makes these outreach programs or co-designing of these technologies and services actually inclusive, what actually makes them work, we applied a narrative synthesis to analyse the data. And by this, we just sort of looked at what the key things that were coming out from the data and compiled them together in relevant sort of groups. So your themes that were had codes within them, so like different topics, to actually identify what actually makes something digitally inclusive, to identify with strategies. So from this analysis, identified 3 key strategies to make something inclusive. So the first one is around a user-friendly design. So making sure your technology is compatible with a load of different devices, making sure it's easy to navigate on the different apps or websites, making sure the content is actually understandable, it's in different languages, and also it's culturally appropriate, and making sure that you have engaging features in there, such as quizzes, to make sure people are actually willing to come back. And this user-friendly design, it had perspectives coming from all the different peers groups, so it was used across a load of different the papers. And we also looked at, okay, what actually makes it a useful thing to do, what actually like facilitates the use in practice. And the things that were coming out is that like if you use this approach, it actually really builds trust in underserved groups who like in the past have distrust healthcare due to prejudice and things like that. So if you add culturally appropriate content, if you give them more information to help them understand this health condition, it helps them to come back, and definitely if it's easy to use, they're more likely to trust it. But it is a really hard thing to actually implement from like a technology development side, because to make sure your app or website is compatible with a wide range of devices, it does take a lot of man hours, so you need the resources there. And also the second theme that we had coming out was around the infrastructure, so providing devices, Wi-Fi, having a centre that people can go to then access that digital healthcare service, and also having non-digital options to access healthcare. So not just giving anyone a link or QR code to access the NHS website, having in-person facilities there, and also having some policies to help implement these things. So having policies that people can access if they're a low income to then get benefits off the Wi-Fi. The only groups that weren't actually included in sharing their thoughts on this kind of approach to being digitally inclusive across the papers was those with limit conditions and age, which is quite interesting. But the thing that does actually help this sort of strategy quite a bit is that it removes quite a lot of the financial barriers from the underserved groups, because it removes the financial barriers about accessing a device or the connectivity, and it removes a lot of barriers to actually accessing healthcare itself. So it actually helps to improve digital health inequities, and even because if you're removing those barriers, they're more likely to actually access the healthcare, so you're removing that barrier. But within the sort of more healthcare side and the more tech development side, it is very resource heavy, because the money to get those devices needs to come from somewhere. So again, it's the resource side that's coming up quite a bit as well. And the last one is around the educational support. So getting educational support to understand how to use your technology from either professionals or family and friends. And this actually really helps people overcome those sort of initial fears and anxiety of using technology, and also promotes independence over time as they learn from others of how to use the technology. And it helps to build a bit of a social network as well. But the thing that sort of really hinders the implementation of this is not actually everyone had access to this kind of support. So not everyone had family or friends to turn to. Not everyone knew where to turn to get that professional support. So having that effective advertisement is really key to implementing this strategy. So from these three key strategies, I sort of propose that there's two key recommendations to advancing digital health equity from the review results from this paper. So one of them is around using a collaborative working approach. So having a co-design element built in from the very beginning of the project to make sure the technology or the service is designed for the users, not only the members of the public, but also healthcare professionals that feel like they're being supported, and also collaborate with different network providers to make sure that those devices are actually be able to be given. You have your different connectivity that actually is accessible for people, and also the different educational services can be provided in a sensible location. And the second recommendation from this paper is to use effective advertisement, because there's no point in offering support and having all these wonderful services if no one actually knows about it. So having effective advertisement to spread the awareness within the communities, to actually know the support's there, and also raise awareness on the tech development side to know what like different regulations they should be following, know what inclusive guidelines they should be following, because it doesn't always actually get used, which is a bit disappointing. So this work is actually being published within Nature Digital Medicine. So I don't know if any of you have read it or not, but I suppose you've had a summary of it already, but I still say it's a good read, but that mentioned me being biased. But I've also had the pleasure of traveling the world a little bit with this one. So I was over in Amsterdam last year presenting the protocol for the systematic review. And then in November last year, I was also in New Orleans presenting the preliminary findings of the review. So I'm very happy with this piece of work so far. And then the third step in the PhD is to actually ask underserved groups, so the cleared groups, what they would actually like to support them in becoming more digitally inclusive. So, and also like what are their thoughts on the strategies that are coming out from the systematic review, to get their thoughts on, okay, so this is going to work for some people, this might not work for others, and how do we support that more inclusive approach? So to do that, we decided to look at the Northeast. Not only has it got the pretty bridges and the nice scenery, it's also got vibrant nightlife, and the football's pretty good as well. So it seems a nice place to look at. And also, behind the nice prettiness, they've got really high rates of health inequities. So people are less likely to live as long as different areas in the UK. And we're also more likely to spend a larger proportion of our lives in ill health or disability. And on top of this, we also have a higher prevalence of those who aren't engaged with digital technology or have a lower digital competency or like digital literacy skill. And then even on top of this, there's been a report that was published, I think it was either last year or the year before, stating that 94% of digitally excluded residents within the North Tyneside were over 60. So definitely these older adults, not only are they less likely to live as long, more likely to face health inequities such as dying prematurely from preventable diseases, they're also less likely to be engaged digitally, and also like their friends and family who are also of that age are less likely to be able to support them because they're probably also likely to be digitally excluded. So it's really, really important that we start to understand the barriers that people in the Northeast actually face, because they seem to be the region that seems to have the most health inequities and digital exclusion. So because these groups are by nature underserved, it's really hard to recruit them. And there's been loads of evidence to sort of back it up about how it's really hard to recruit underserved groups. So I couldn't really just use like, okay, put an advert on social media, which is a popular way of recruiting people right now, because obviously by nature they were digitally excluded, so it wouldn't reach them. So I took a five-step approach to recruiting these people. So the first one was actually identifying relevant groups that I should be contacting. And by doing this, I built like a massive network, which is represented by this little mind map here, of different organisations, different support groups that I might be able to recruit individuals from. And then once I've identified them, I'll contact different groups to sort of set up recruitment sessions. And these recruitment sessions were in person at the centre that the group or support group of the charity was centred at. So I'd go along for about 5-10 minutes, present my little project, sort of brief them about what it's about. And if anyone was interested, I gave them an expression of interest form, so then I can get the contact details and all this kind of thing. And also in that expression of interest form, they noted down like their ethnicity, their socioeconomic background, if they live like locally as well. So it's put like the first chunk of the postcode, so I could see if they were in a deprived area or not. So then I went away and I had a look at these expression of interest forms, and I picked people who identified with 2 or more of those clear groups, because I wanted to have that element of intersectionality within my sample. And then once I picked the people that I wanted, I started to contact the individuals I'll be interviewing, or I asked them if they wanted to be a part of a focus group instead as well, to be a bit more inclusive, as I heard from a cinema that different ethnic groups sometimes feel a bit more confident expressing their opinions in a different group that sort of share the same background as them, so they don't feel as self-conscious. And then after I'd done that, I then started organising where I'm actually going to have this. So I reached out to different libraries, different community centres, and started booking rooms that way as well. And then from all this networking and pulling things together, I ended up recruiting from 5 different organisations and also use a snowball sampling approach to gain a few others as well. So as you can see from this map, I had a widespread of different areas from North Tyneside, which is kind of where like Killingsworth, this side of the water, and also South Tyneside, this side of the water. And to give a bit of perspective, those lovely bridges I was showing you before, they're about here. So it's quite a good spread that I managed to recruit from. And then what I ended up getting in my sample, so I ended up getting 29 participants in total. 11 of them took part in an interview and 18 of them took part in 1 of 4 focus groups. I had a majority of female sample, as it normally is in sort of this kind of research, but I was able to get all my sample to identify with at least of the 2 of the clearest domains, which is why these numbers are a lot higher and don't add up to 29, because some of them were part of like the culture, low education and age kind of categories. But you can see from these numbers, I got a decent spread of the whole peers domains, which was fantastic, since these people are usually hard to recruit within research. And then from these interviews and focus groups, I conducted a reflective thematic analysis. I'm not quite sure how many people do qualitative research, but the thematic analysis involves 6 key steps. The first one is familiarising myself with the data by rereading the transcripts over and over again. Then I identified sort of key topics that were coming out from these transcripts to generate initial codes. And then I kind of pulled those codes into themes, which are basically just like a group of codes that have similar meaning or like relevant to each other. And then I started reviewing these themes with my supervisory team and one of the colleagues who helped us with one of the interviews, because the participant only spoke in Arabic and I am speaking English, so one of my colleagues was able to support with that. And then I defined my key themes and written it up as a chapter. Then the reflective side of it comes from me reflecting on the field notes, any thoughts, any observations from the recruitment sessions, the interview/focus group, and also at each step of this thematic analysis. So it was more a reflection of my experience rather than me just looking in the mirror at every step of the way. So from this reflection process and the thematic analysis, we identified 3 key themes. So the first one centered around the barriers to actually accessing healthcare from digital means. So this actually included the challenges at various digital touch points, so such as booking appointments via the NHS website or even a phone call. This included also when people got like an SMS message, like a text message with a link to verify their appointment or to do a pre-appointment assessment, they couldn't always access it. So that caused a lot of problems as well for people, and often there wasn't really an alternative. So there was a focus group of a deaf community, and a lot of them were saying that one of the GP surgeries around them only allowed appointments to be booked via a phone call, because they were deaf, they had to then rely on family and friends. So that wasn't really fair. And then someone else also brought up that when they got the text message about like our pre-assessment or confirmation of an appointment, there was no contact number and she didn't have access to Wi-Fi. So then she ended up ringing up the surgery, but they didn't know anything about it, because it was an automatic message. So it was a whole vicious circle. And then some people actually suggested some improvements to support their access to healthcare via digital means. So a lot of them were saying that if the healthcare service wants to go more digital, then they should really be providing devices, connectivity, and have a record of who has access to what, so then they can provide a communication strategy that actually is appropriate for them. So if someone is deaf, you're not asking them to have a phone call to catch up about something because they just can't hear, those kind of things. The second key theme was around actually using the technology for healthcare purposes itself. So a lot of people were saying that they had a lot of anxiety around using the technology and even learning how to use the technology. So this quote was amazing when I was looking back over it, and it was saying that using the internet, it's like fireworks are coming in towards my brain because I just don't understand it. And even when she tried to learn how to use it, she just got really frustrated and overwhelmed very quickly. So it really put her off actually using technology for healthcare. A lot of them were saying that a lot of sort of tasks that healthcare providers were asking to do require a high level of digital literacy skill, such as sending a photo of a rash or wound over COVID to them. And a lot of people just didn't know how to attach a photo to an email or upload it in any other way, so they really struggled with that. And there was a lot of issues as well. I came up with one of the focus groups from an ethnic minority group, who were also survivors of domestic abuse. And they were saying that their husband used to not teach them how to use the NHS app or teach them how to use any technology, so then their husband could control their healthcare and things like that. So there's a whole issue around relying on social support to help people use technology. But moving forward, people did say that they would like to be more involved in like a co-design process to improve the navigation and ease of use of different services that are coming out. So if you're asking someone to upload a photo, making sure there's instructions there, making sure people are involved in the co-design of those instructions. And also provide an educational service provided by healthcare professionals or the voluntary sector, so then people know that there's a support group out there for them if they're in those kind of situations when they want to learn but they haven't got the support network available to them. And then the final key theme is around perspectives of clinical usefulness of the technology. So some people were actually like really excited about the use of technology within healthcare, because there was this lady who was deaf, and well, she was deaf in one ear and partly deaf in the other ear. She was at this consultation, she couldn't really hear anything. So the healthcare consultation person started typing the questions, that really helped her understand what was going on. And a few other people have sort of thought that it was really useful using the NHS app to order the repeat prescriptions and things like that. But then also there was quite a lot of people who just didn't trust the technology to hold information that was that personal to them. They were a bit scared that it would get hacked or released somehow. And a lot of people were concerned that the technology just isn't reliable for that kind of really important information. They were really concerned about how it could end up like the post office scandal, where people just got put in prison when the technology failed and it wasn't their fault, and all this kind of thing. They were thinking healthcare professionals that could end up the same thing. And also they're just sort of saying that the technology at the moment that we have isn't that sensitive and specific enough to actually help with medical diagnosis. That was their perspective of it. And also concerned that if we end up using like AI or things that are more in health consultations, they would lose a lot of that in-person interaction that they were actually quite valued within the healthcare service. So we've only sort of just finished writing up that piece of work and submitted it to a few conferences. So we've been quite lucky with this one as well, and got accepted in a conference in Lisbon for this November coming up, and also a conference in Cardiff. So the conference that we held in Cardiff, that's the UK Public Health Conference. And through that, this bit of work will actually be published within the Lancet as a conference proceeding. So I'm really looking forward to presenting this work at both those conferences as well. And then we're also working with a group called More Than Minutes to design like a visualization of the different ways digital health technologies and services and systems should be tailored to meet the needs of the different underserved groups that we have that are at risk of digital exclusion. And this is to then be given to those different voluntary sectors, the support groups, the charities that helped work through the qualitative research groups. So then members of the public can actually see what's actually coming out from this work, because it's only really fair that if they've helped with this work, they get to know what's actually coming out from their work and how it's been influenced moving forward in future work. So we're busy working with them at the moment, and I'm really excited to sort of see what that group brings forward and puts an image forward. So the fourth step in this PhD is the perceptions of stakeholders. So I'm not going too much detail with this one because I've literally just finished off the data collection. So I'm still sort of, I would say I'm about halfway through the analysis. So I'm not going to give out too much information on that, but I did end up interviewing about 17 stakeholders. This ranged from people on the ICB board level, different consultation groups, different health network organisations, different charities or local health organisations, including the Public Health Wales groups as well, and some groups up here in the northeast. I interviewed a few people from academia and a few healthcare professionals as well. And I'm taking a similar approach to the analysis, the reflective thematic analysis, then all my field notes and my thoughts and observations are then tied into that analysis to really bring out the thoughts of these participants. And the final bit of the PhD will be to pull into some recommendations and guidelines together. So as the fourth stage isn't complete yet, this obviously is not complete, but I'm hoping to get that started sometime before Christmas to get the thesis in April. And then just to finish this all off, if you've dozed off halfway through my presentation, it's okay, because these are the key things we should be taking away and start to be using within our research. Is that from the very beginning, we need to make sure that any digital project we're working on is inclusive. So identify what support participants might be needing, whether that's a video guide, a written guide, or a one-to-one session with them to actually make sure they feel confident in using the technology, or even providing them a phone or the SIM cards. And also, can a non-digital route be provided? So it's okay being, oh, technology is amazing, but not everyone wants to use it. Can we make a non-digital route that's in person and more appropriate to someone's needs? We also need to start working more collaboratively, so involving end users from the very, very start of a project to make sure it is suitable for their needs, and also with different voluntary sectors or different third-party sectors to make sure we can bring in those devices, make sure we can bring in those SIM cards, and have the support there and have that supportive infrastructure from the research side as well. And also we need to raise awareness, not only of the work that's ongoing, to make sure people are actually aware that digital exclusion is a massive issue and probably going to get even worse as the cost of living gets higher, so people are less likely to be able to afford devices or SIM cards, and also as technology is used more and more within healthcare, but also within the community and the voluntary sector to make sure they're aware of what support is available, so if they come across someone who's struggling, they know where to signpost them to. I think that's everything. So thank you very much for listening, and I'm open for any questions.